Welcome to this webinar on Plaquenil Retinopathy. I am Dr. Julie Rodman. In the next few minutes, I am going to discuss with you the guidelines and screening recommendations for our patients taking Plaquenil. So the first question is, what exactly is hydroxychloroquine, better known as Plaquenil? Plaquenil is a disease-modifying antirheumatic drug, or DMARD. It was specifically formulated as an antimalarial and now has many usages. Some of these more common usages include the treatment of rheumatoid arthritis, lupus, and other inflammatory and dermatologic conditions. Hydroxychloroquine is a metabolite of chloroquine. However, it is a more effective and safer medication. It's more effective because it has a longer half-life, thus it requires less drug to be efficacious. Hydroxychloroquine has a component, or the mode of action requires that it binds to melanin in the retinal pigment epithelium. That is why clinically we see the manifestation of bullseye maculopathy. So if you recall the retinal anatomy and we look over here at Bruch's membrane, right above Bruch's membrane we have the retinal pigment epithelium. The retinal pigment epithelium is made up of melanin, or pigmented cells. So when we ingest Plaquenil, or when we take Plaquenil, it binds to the melanin granules, and that is why, again, we see a clinical manifestation of bullseye maculopathy. So I always like to look at the American Academy of Ophthalmology screening guidelines because they really put out the most recent and useful information that we can apply in our clinical practices. So certain risk factors have been identified as being pertinent in the management of our patients on Plaquenil. The two most significant risk factors are dose and duration. So what I'd like to do is I'd like to talk about the clinical guidelines, and then I'm going to present a case of a patient on Plaquenil and how we would apply these clinical guidelines to her management and care. So the first recommendation is dose. The AAO recommends a maximum daily dose of hydroxychloroquine of less than or equal to 5 milligrams per kilogram of real body weight. This was changed from previous guidelines that identified it as ideal body weight. They found that looking at real body weight was more representative or accurate than looking at ideal weight. So again, less than or equal to 5 milligrams per kilogram of real body weight. Duration is the second most significant risk factor. So when a patient is taking Plaquenil at the recommended dosage, and that's important, okay, at the recommended dosage, meaning they're taking less than or equal to 5 milligrams per kilogram, the risk of toxicity up to 5 years is under 1%. So it's a very, very safe drug when taken at the recommended dosage. And up to 10 years, it's under 2%. Okay, so very small statistics. However, after 20 years, that percentage spikes up to over 20%. And again, remember, that's at the recommended dosage. We have a lot of patients that are taking this medication at a stronger dosage than what the AAO recommends, and that's going to make these statistics even higher. When you look at this graph that the AAO published, it shows you on a kind of on a depiction what I was just referring to. So on the bottom here, you can see the duration of years that the patient is taking the medication. So 5, 10, 15, and so on. These little dotted lines show you the dosage. So the little blue dotted line means the patient is taking less than 4 milligrams per kilogram. The purple hash line is 4 to 5 milligrams per kilogram. And the green line is greater than 5 milligrams per kilogram. So when you look at the different dosages in relation to duration, you can see how the percentages are arrived at. So let's say you have a patient taking either less than 4 or 4 to 5 milligrams. That would be these two lines. You can see that the percentage of toxicity stays below 50% when you're on these normal dosages. However, after or when you're taking greater than the recommended dosage, which is again less than or equal to 5 milligrams per kilogram, when you're taking more than that, look how that number spikes up to almost 70% affected at the 25-year mark. So this is really just a diagram showing what we mentioned in the previous slide, that dose and duration work together in determining the patient's risk of toxicity. Other major risk factors are if the patient has concomitant renal disease. We measure that via a subnormal glomerular filtration rate. And really this means that the patient cannot filter out toxic substances, which allows for the accumulation of the medication in the bloodstream. Also, the use of tamoxifen has been shown to be a problem. So concomitant use of tamoxifen with Plaquenil is a significant risk factor. So what are the recommended screening guidelines? Okay, what do we want to do to screen these patients? Well, we certainly want to screen them at baseline. Okay, we want to have them come in as soon as they start the medication. And we want to look at their fundus, right? Because we want to evaluate how healthy their macula is. We want to see, do they have any other concomitant diseases? Do they have AMD? Do they have drusen? Okay, we need to establish a baseline. The AAO also recommends the use of visual fields and OCTs. They specifically state if maculopathy is present. However, in my practice, I try to obtain a baseline 10-2 and a baseline OCT on all patients on Plaquenil. Okay, and we're going to talk a little more about the visual field further on in the presentation. Once we establish a baseline test, then we can wait, and assuming everything, let's say, is normal, we can wait 5 years to do the next exam. The reason being, if you look back at this graph, from 0 to 5 years, there's almost zero risk of toxicity as long as the patient's taking the recommended dosage. So again, you can change this in your practice. I still tend to see my Plaquenil patients pretty frequently, but if you go by the AAO guidelines, they say that after the first 5 years, you should begin an annual screening. Now, if the patient has concomitant risk factors, then obviously we want to watch them more closely. So let's look at an example here of a 65-year-old Caucasian female. Okay, I want to show you how we can apply the clinical guidelines to this case. She comes in complaining of central darkening of her vision that has gotten progressively worse over the years. She has a history of rheumatoid arthritis, and she's had it for greater than 20 years. Okay, her best corrected vision was 20/40 in both eyes. Her medications are on that orange chart on the side. She was on methotrexate, and she was taking Plaquenil 400 milligrams or 200 BID for 20 years. Okay, so we're going to assess kind of her specific risk factors as we move through this. She was otherwise healthy. So the first step that the AAO says is look at the dosage. So I put up here, recall the ideal dosage should be a maximum daily use of less than or equal to 5 milligrams per kilogram. Okay, so the first question to ask the patient is, how much do you weigh? All right, and hopefully they're going to be honest with you. So let's say this patient weighs 150 pounds. The first thing you want to do is you want to put the pounds into kilograms, okay, so that we can use this conversion. So 150 pounds converts to 68 kilograms. Then you can divide her dosage, which is 400 milligrams, by her weight, which is 68 kilograms. And that comes out to 5.88 milligrams per kilogram. So then you say, well, the recommended dosage is less than or equal to 5 milligrams per kilogram. So this lady, based on her body weight, is taking a dosage that is higher than recommended. Okay. The second thing we want to evaluate is the duration, right? We said that the length of use or the duration of usage is a significant risk factor. So again, at the recommended dosage, the risk of toxicity is very, very low. However, after 20 years, it spiked up. Remember though, this young lady is taking a higher than recommended dosage, and she's been taking it for 20 years. Okay, so those are two issues that are going to make her risk of toxicity much higher. So if you recall this graph here, okay, this showed us, I tried to put the orange arrows here to show you where this lady falls. Remember that if you're taking greater than 5 milligrams per kilogram, that would be the green line. So if you look at 20 years and you go up to the green line, you can see that she has more than a 50% chance of having toxicity. Okay, so that's a pretty significant number. The other risk factors that we want to look at are, does she have any other concomitant diseases? So does she have renal disease? No. Is she taking tamoxifen? No. Okay, so her major risk factors were her dosage and her duration of use. Okay, so when we look at her fundus, we're expecting, based on her symptomatology and based on her risk factors, we're expecting to see maculopathy. So basically, when you look here, you can see it's pretty obvious that she has what we call a bullseye maculopathy, which can be defined as a ring of parafoveal, meaning here's your fovea, so it's parafoveal, a ring of parafoveal RPE depigmentation sparing the fovea. Okay, so classic bullseye maculopathy, which is why she was explaining paracentral scotomatous lesions. When we did a 10-2 on her, you could see that she had dense ring scotomas bilaterally, and these are going to correlate exactly with those areas of bullseye maculopathy. The fovea seems to be spared, at least initially, and then she's got this area of dense scotomatous area around the fovea. When we look at her OCT, I want to this slide here really just is going to show us what that classic Plaquenil patient is going to look like, and then I'll show you hers. So on the top of this slide, you can see what a normal OCT looks like. So recall the inner retina here should look perfect. Plaquenil is not affecting the inner retina. We have our external limiting membrane, which should look very, very healthy. The ISOS junction, very nice and intact, and the RPE. In a patient that has plaquenil toxicity, remember that we're looking at that parafoveal area. We're going to get thinning or loss of tissue in the parafoveal area. So if you look at the RPE, you can see that the RPE out here looks fine. So does the ISOS junction. It looks a little moth-eaten on this side, but the area of emphasis really is this area here, where you can see there's a complete loss of the ISOS junction and some sinking in of the outer retinal tissue, and also on this side from here to here. Okay, loss of the ISOS junction and that sinking or collapsing down of the outer retinal tissue. However, in this particular case, there's preservation of the ellipsoid zone and ISOS junction and RPE. This results in what we call a classic flying saucer sign. So this area here looks almost hyporeflective due to the changes that are happening in the parafoveal area. So let's look at our patient. Our patient had a pretty advanced stage of plaquenil toxicity with a pretty prominent bullseye appearance. So when you look at her eye, again, you can see that in the real, extrafoveal area, it looks good here and it looks good here. However, centrally, she doesn't have that preservation of the ellipsoid zone that we talked about in that kind of, quote, normal plaquenil toxicity appearance. She has loss of the ISOS junction all the way from here to here with that sinking in of the outer retinal tissue, really resulting in a complete effect. The whole area here is completely affected. Okay, so no really sparing in this patient of that foveal zone. Same thing here. Okay, you can see that at that normal foveal pit, all of the tissue in that outer retina, including the photoreceptors, ISOS junction, RPE, are affected. And then you get the resulting posterior shadowing that we talked about because of the loss of the overlying RPE or damage to the overlying RPE. So this really shows you that in cases of advanced plaquenil toxicity, the fovea can become involved, and that's really when the patients start to develop symptomatology. When it's extrafoveal and it's kind of off to the side, they may notice that there's some graying kind of in the side of their central vision. But once it affects the fovea, that's really when you're going to start seeing the symptomatology. So, just a clinical pearl, really, as far as Asians go, the literature is saying that Asians tend to get more extra macular, peripheral extramacular distribution versus that central distribution that we see in our regular Caucasian patients. So when you're doing testing on an Asian patient, make sure that you don't get a 10-2, but you get a 24-2, because that's going to give us more, it's going to allow us to visualize more of that tissue outside of the foveal area. And on OCT, you can see here that, again, there's been preservation of this whole area within the fovea and right at the parafoveal area. However, the tissue changes are pretty prominent out in that extramacular area. Okay, so make sure that you're getting an OCT scan that really gets far out and a 24 or 30-2. So the clinical pearl here is that maculopathy is not reversible, okay? And damage may continue to progress even after the drug is stopped. Once you see the bullseye maculopathy, we are too late. So the goal here is that if we get the patient in for a baseline exam right when they start the medication, and then make determinations or decisions based on what we see each time that we screen them, that will help us for early detection, which will prevent, hopefully, the patients getting that central involvement that happened in this particular patient. Okay, so it's very important to co-manage these patients with their rheumatologist and to be in good communication regarding the side effects of Plaquenil so that the rheumatologist is aware. Now, there are situations where this is the only medication that may be effective and we don't have very many options, but it's not the optometrist or ophthalmologist's decision to make regarding cessation of the drug. So again, super important to screen these patients, follow the recommended dosing guidelines so that these patients have a minimal risk of toxicity. Thank you so much for joining me for this webinar. I hope that everybody feels more comfortable now with screening our Plaquenil patients and taking the best possible care of them that we can. I look forward to seeing you at future webinars.